All right, so I couldn't do the video over PowerPoint, but hopefully this will be helpful enough where you can hear me talk through everything. So these are the criteria for schizophrenia. So you have to have 2 or more of these symptoms. So delusions, those fixed false beliefs. Hallucinations, those inaccurate sensory perceptions. Disorganized speech, disruption in the process of speech where you aren't able to articulate words or bring together a coherent thought. Grossly disorganized or catatonic behavior, where you have bizarre or disrupted behavioral patterns, dishevelment, uncontrollable childlike silliness, extreme agitation, inability to perform simple activities of daily living, etc. Some people see 3 and 4 as their own class of symptoms, but others argue they are just part of the positive symptoms. And then 5 are the negative symptoms: lack of emotion, speech, or motivation. And this could also include lack of apathy or withdrawal in general. Their functioning is going to be markedly impaired, and they have to have signs for at least 6 months. And at least 1 month of symptoms in full and active form. All right, there might be this distinction between type 1, dominated by positive symptoms, and type 2, dominated by negative symptoms. Type 1 may be related to biochemical abnormalities, and type 2 might be related to structural abnormalities. All right, so delusions. Again, these are those fixed false beliefs, and these are differentiated between bizarre, things that do not relate to reality at all, and non-bizarre, which is potentially relating to life experiences. So these are non-bizarre, are a little bit more grounded, but still not realistic, right? So delusions of persecution, the idea that you're being attacked, followed, or controlled. Delusions of grandeur, the belief that you are an especially important and powerful person. Delusions of reference, the assumption that external events are connected to you. Delusions of sin, the belief that you are guilty for various sins you've committed when in reality you haven't done anything wrong or to feel guilty about. Hypochondriacal delusions, beliefs that things are contaminated and focus on illness. And nihilistic delusions being beliefs the world is going to end. Now, in terms of positive symptoms, with the hallucinations, these again come up in the 5 senses. So auditory are things you hear that aren't really there. Visual are things you see that aren't really there. Olfactory are things you smell that aren't really there. Gustatory are things you taste that are not really there. Tactile are things you feel that are not really there. Auditory and visual are the most common, and sometimes people are terrified of their hallucinations, whereas other people might find them comforting or reassuring. And then some people know the hallucinations aren't real, while others can't distinguish between that and reality. All right, so disorganized speech or thought. This is where we were when everything went down, literally. So, loose associations. This is a sequence of logically disconnected thoughts. So the person will be talking about various things, but they won't go together to make a coherent thought. My problem is insects. My brother used to collect insects. He's now a man, 5 foot 10 inches. You know, 10 is my favorite number. I also like to dance, draw, and watch TV. Neologisms are made-up words, like saying head vise instead of headache, or this desk is a cram style. He's an Easter horn head. Clang associations are nonsense sequences of rhyming of like-sounding words, like I'm out, sprout, shout, shoot me, shoo me, shoo, shoo, fady, shady lady. How are you? Well, hell, it's well to tell. Echolalia is repeating verbatim what other people say, like a parrot, basically. Echopraxia is repeating the gestures of others. Word salad is the most extreme. It's totally incoherent, and it's just a random collection of disorganized words. So it would be something like this, only said out loud. We also have this grossly disorganized behavior. It's a wide variety of bizarre or disrupted behavioral patterns. And this can include things mentioned before, like dishevelment, agitation, and childishness. But it can also be more severe and include catatonia, which is a set of psychomotor symptoms ranging from extreme immobility and unresponsiveness to extreme agitation. Catatonic immobility sometimes include an unusual symptom known as waxy flexibility, in which a patient's limbs, which are often held in rigid postures for hours, can be bent and reshaped as though made of wax. All right, so let's talk about the negative symptoms. And again, the negative symptoms are not as dramatic as the positive symptoms, but they're just as incapacitating, if not more so, because they're essentially like having very severe depression. And they rob people of some basic human attributes. So affective or emotional flattening is a reduction or absence of normal emotion. So schizophrenics may appear to be emotionally blunted, or they may have a short range of affect. They may also display affect that's inappropriate to the situation, like laughing when they're talking about something sad. Alogia is minimal or absent verbal communication. Someone may be entirely mute or only give short, blunted responses to questions. Thought blocking is when you try to talk, but you can't. They just have the inability to get words out, even though they're trying really hard to communicate. Avolition is reduced or absent motivation. Many people with schizophrenia find it difficult to complete tasks, even such things as making a bed or going for a walk. They may sit still all day and show little interest in planned or goal-directed behavior. Then there's anhedonia, which we've talked about before with depression, and it's a loss of a sense of pleasure from activities you would usually find pleasurable. The other important diagnostic criteria is the temporal criteria we talked about, and then again, having significant impairment or deterioration over time in an individual's ability to function in his or their own social or environment or occupational environment. So they have significant work and relationship difficulties. 60 to 70% of people with schizophrenia never marry, and they have higher rates of divorce than the general population. Another indicator of their inability to function is that the socioeconomic status of individuals with schizophrenia is below that of those of their family of origin. So that's really unusual. Typically, we see the other direction, and that phenomenon is actually known as downward drift. So downward drift is when they do worse off than their parents. All right, there are specifiers for schizophrenia. I'm going to move through these pretty quickly. Some of them are pretty obvious, right? Like, it's your first episode, and is it like you're having the episode right now? That's acute. Partial remission might be, there's a period of time where there's an improvement after a previous episode, and that's maintained. And the criteria for the disorder are only partially filled. And then full remission is there are no disorder-specific symptoms present. So again, you can have multiple episodes with the same specifiers. Continuous is where symptoms fulfilling the diagnostic criteria of the disorder are retained and remaining for the majority of the illness course. So they basically don't get relief. Unspecified would just be you need more information to say which they're in. And then there is a specifier of with catatonia. So having the catatonia we just talked about. There are other related disorders that have probably the same reasons they happen, but are slightly distinct from schizophrenia. So the schizophrenic spectrum is disorders that fall along a continuum, but you could say they all have like a schizophrenic flavor. Schizoaffective disorder is where someone is simultaneously diagnosed with a mood disorder and schizophrenia. So a person may also meet the criteria for a manic episode or a depressive episode along with schizophrenia. And you would have to specify whether they were the bipolar type or the depressive type. Schizophreniform disorder really only differs from schizophrenia in terms of the temporal criteria. So for schizophreniform disorder, you have a psychotic episode with all the features of schizophrenia, but it hasn't yet lasted a month. It's lasted at least 1 month, but you haven't gotten to that 6-month cutoff. So this allows people who are experiencing psychotic symptoms but haven't met that 6 months to get treatment. And ultimately, about 2/3 of these cases continue beyond 6 months, in which case the diagnosis would be changed to schizophrenia. Brief psychotic disorder is a psychotic episode with all the features of schizophrenia, but that lasts less than a month. So this is what you'd be diagnosed with before you have schizophreniform disorder. People diagnosed with brief psychotic disorder, though, usually return to normal functioning. So oftentimes this really is just sort of a one-time thing. Oftentimes people won't necessarily seek treatment right away when they start to develop, say, symptoms of schizophreniform disorder, for example. And then delusional disorder is when the person has non-bizarre delusions lasting at least 1 month. That person becomes delusional over an extended period of time without any of the other symptoms of schizophrenia. So there's some speculation, for example, that this might be what like John Hinckley Jr. had, although, the idea that a famous movie star is infatuated with you, and if you only, killed the president, he could have had full schizophrenia as well. In terms of demographics, people who are higher risk, have higher rates of schizophrenia, include people who are from lower socioeconomic groups, African Americans, urban dwellers. So it's typically associated with poverty is what you're seeing, which is understandable because, as we've talked about before, poverty really is linked to stressors, which may be more linked to bringing this out. Also, it does seem to be at least somewhat genetic. So if you have biological relatives who have some sort of schizophrenic spectrum disorder, you're at higher risk for developing it as well. There is one study that shows that later born siblings are at lower risk. It's one study, so who knows, right? I don't know how much stock I place in this. All right, so when does it start? What happens? There are 3 phases or courses of the disorder. Prodromal is the first stage in which the symptoms are just starting to develop. Active is where you are actively having psychotic symptoms, delusions, hallucinations, what have you. And then residual is the 3rd phase in which individual is no longer psychotic, but they still show signs of schizophrenia. Onset typically is from the early to late 20s, and it's rare to begin before adolescence. But it's been diagnosed in individuals as young as 5 years of age, so it can happen. It's actually equally likely to affect people of all genders, but we tend to see a later age of onset for women, and that women tend to have higher premorbid functioning and fewer negative symptoms. All right, so this is the biological perspective. I'm actually going to skim over this because y'all don't need to know this on your exam. So if anyone's really interested, definitely feel free to read more about this in the book. But again, I'm not going to test you on this. I'm just going to skip through it. But I do want to talk about biological treatment because this really is the first line treatment for individuals with schizophrenia. You need to use medication, almost certainly. So the first generation antipsychotics, which were developed in the 1950s, really only reduce the positive symptoms. They don't treat the negative symptoms at all, and they have some potentially severe side effects, including tardive dyskinesia, which is where the person has involuntary movements of the tongue, jaw, trunk, or extremities. And then neuroleptic malignant syndrome is a rare but fatal condition characterized by muscle rigidity and elevated body temperature. So you certainly must be very carefully monitored if you are on any of these medications. Second generation antipsychotics treat both positive and negative symptoms, but they're not quite as affected. Patients are still moderately to severely affected by their symptoms. However, they do have less side effects. In terms of cutting-edge biological treatment, one of the things people are trying to do now is to identify at-risk individuals and treat or prevent the disorder before it fully develops using antipsychotics. So this person may have never developed full-blown schizophrenia, but this may help them diminish some of the symptoms they have experienced, like the negative symptoms like flat affect, lack of motivation. In terms of the cognitive perspective, the idea here is there's probably abnormal attention processes. So in terms of positive symptoms, they may be paying too much attention or over attention to irrelevant stimuli. So they might have difficulty coping with stress because they're flooded with so much information. Delusions here might be when clients attempt to explain their odd subjective experiences to themselves. So typically when I am in a classroom, I talk about, like maybe if I had schizophrenia, I'd be paying more attention to like the whir of the projector than I would be to, the professor talking. Negative symptoms. So under attention to important stimuli might be the result here. So you're paying so much attention to the irrelevant stimuli that you can't pay attention to the stimuli that are actually important. So they just don't have a normal orient response, essentially, meaning they don't exhibit physical changes associated with sharpened attention, like eye movement and muscular facial changes, which is linked to those withdrawal and apathy symptoms that we've talked about. Now, in terms of cognitive treatment, cognitive rehabilitation uses techniques to decrease both over and under attention and help people to learn to focus on what they need to focus on. And then cognitive restructuring, this element from CBT that we've talked about for other disorders, is actually interesting. So you can challenge delusional beliefs this way. So therapists will emphasize that normal but exaggerated cognitive processes and emotional problems are underlying their symptoms. So persecutory delusions and hallucinations, for example, are believed to be exaggerations of expectable reactions to fear and mistreatment that individuals with schizophrenia often experience in their daily lives, because that does happen. Aaron Beck, who we watched videos of earlier in the semester, has actually spent his 90s, because he doesn't know how to retire, studying how do we use CBT to help people with schizophrenia. And it's very interesting and it's working, which is really cool. In terms of behavioral theory here, as always, we go back to learning principles. So they've argued that reinforcement of abnormal responses through operant conditioning can contribute. So for example, maybe they get attention for their disorganized speech. And when you're given attention for that abnormal behavior, that will continue in order to get that positive attention, because positive attention in and of itself is reinforcing. Now, in terms of behavioral interventions, Reinforcement-based techniques based on operant conditioning principles can be really helpful here. So you try not to reinforce the inappropriate behaviors and increase desired behaviors. So in inpatient settings, for example, they will use what's called a token economy, where clients who engage in desired behavior earn coin-like tokens that will be exchanged for privileges, like watching TV or having extra snacks. So the best analogy in our, sort of day-to-day world is something like Chuck E. Cheese, right? Where you would get tickets and then you could trade them in for something. And social skills training is another, sorry, I had points about that on the slide and I didn't know. Social skills training is another important piece here where you educate clients about appropriate interpersonal behavior, and this improves their social and interpersonal functioning. So it does work. All right, so family systems theory, just like with anorexia, argues that the family environment may be one of the main roots here. So that families that are overly hostile, confusing, or pathological family environments possibly contribute to schizophrenia. And one of the key features here is double-bind communications. And this is when parents give contradictory messages to their child, such as, "Be independent, but never leave me." And this puts the child in a no-win situation in which they don't know what to do in order to make their parent happy. Expressed emotion is another key feature of this family dynamic, and this is there when there are high levels of criticism and over-involvement among family members. So it's kind of similar to enmeshment with anorexia, but a little more distinct. So it was found that in studies that there are high levels of expressed emotion in families of individuals with schizophrenia, and when these levels decrease, the functioning of the schizophrenic family member does improve. Or when expressed emotion levels increase, then schizophrenic family members actually relapse. So the way you would treat this would be family systems interventions, where you would focus on reducing hostile, confusing family environments and expressed emotion. Okay, so what about the social cultural aspect here? So the social cultural theory here focuses on larger social and institutional forces that may play a role in the development and treatment of the disorder. Sociocultural researchers have found that people with low SES and people who live in urban settings, and again, those two things do tend to be correlated, unfortunately, have higher rates of schizophrenia. So they believe that urban poverty may contribute to developing schizophrenia. The medical establishment itself is also thought to contribute to ongoing pathology suffered by people with schizophrenia. So dehumanizing treatment of people with schizophrenia in medical and sociocultural institutions are believed to contribute to the patient's symptomatic behavior. It's really hard to get better if everyone thinks that you never will. In terms of how would we intervene in this, vein? So Milieu Treatment is one of these. This is an institutional treatment philosophy in which patients take active responsibility for decisions about the management of their environment and therapies. And this is an effort to reduce that dehumanization of schizophrenic patients that occurs in some institutional settings. There's also what are called assertive community treatments, which offer frequent and coordinated contact with a wide variety of professionals in an effort to decrease relapses and rehospitalizations. Another thing I should mention here is when I was on my residency, the Medical College of Georgia, one of the things they use is what they call a consumer-focused approach, which is even more empowering for folks. And it incorporates peer therapy, essentially. So people who themselves are diagnosed with a severe mental illness, but are recovered enough that they can engage with other people, offer support, sort of showing you can get through this. So it's a quick summary here. There were subtypes In the old DSM, we don't have those now. There's a whole bunch of different reasons why it happens. And successful treatment rarely includes complete recovery. Unfortunately, this is a disease you tend to have for the rest of your life. And eventually, you may be able to cope with it and live with it, but for some people, they just might require constant care for the rest of their lives. So sorry again that I had all those crazy problems today. As you all said, we're all just going to blame it on Cox. I should be able to upload this because I'm seeing green on my Wi-Fi here. And please email me with any questions that you have. Take care.